Welcome to the class and welcome to chapter 15 as we get started here shortly. Chapter 15 of our class focus on OBGYN. We're going to talk about it just a little bit and understand the surgical intervention that occur in the operating room when concerning a pregnant female as we continue on. Now, this chapter will focus on a lot of different areas when it comes down to surgical procedures from the surgical tech perspective and also from the nursing staff. In general, we just consider it to be from the surgical staff perspective. After studying this chapter, the final goal is for us to be able to recognize the relevant anatomy and physiology of female reproductive system. We should also be able to summarize the pathology of female reproductive system that normally prompts surgical interventions and related terminology. At some point, we'll be able to determine special pre-operative obstetric and gynecologic diagnostic procedures test in the operating room as we go on, and then be able to determine some special pre-operative preparation procedure related to OBGYN. Now, this chapter also allows to indicate the names and uses of OBGYN instruments, supplies, and medications that will be used or that are being used today. Indicate the names and use of special equipment related to OBGYN surgery. Determine the intraoperative preparation of the patient undergoing OBGYN procedure. Summarize the surgical steps of OBGYN procedures. Interpret the purpose and expected outcomes of the OBGYN procedure. A lot of different things we'll try to identify or go over in review of this chapter. By the conclusion, you should be able to recognize the immediate post-operative care and some complications that normally occur in OBGYN surgery, or other might refer to it as GYN surgery. Assess any specific variations related to pre-operative, intraoperative, and post-operative care of these patients. A lot of different things that we'll go over, but as we get started here, one of the major part, or one of the main focus of this chapter is to understand the anatomical position or the anatomical structure of a GYN, or pretty much of the female anatomy. And that will be one of the main focus that we will be going over here today as we get started. I hope you are ready. We'll get started here shortly. Now, looking at the introduction of obstetric and gynecologic surgery. If we look at obstetric and gynecological surgery, one of the things that we normally focus on is we automatically shift our attention to the female anatomy. This is a specialty in the field of medicine that is a specialty that normally focuses its attention on female after the beginning of menstruation. Now, the attention is given to a pregnant patient and issues concerning with fertility. Now, the gynecologic section of it focus on female reproductive system and related problems outside pregnancy. If we look at it, if you look at the traditional aspect of it, we look at physician and normally practicing in this specialty or field seems normally see patient for both obstetric and of course a patient of gynecological reason. Because again, if you're looking at the obstetric part, that is focusing on the female post-menstruation. Gynecological section of it now, that's a little bit different. So you have to understand these two things. Now, a GYN doctor will not only focus on one, they focus on both aspects of it because they're looking at the patient as a whole. Moving forward, you'll also see gynecologists. These individuals now focus on female reproductive system and the related problems that they normally have outside of the pregnancy. And then you look at the instrumentation that will be available. There are specific instruments that are used in this type of procedure, whether it becomes an emergency or non-emergency surgery or cesarean section, or it could be another thing that you could look at from a different perspective. Now, there could be some instruments that are being used or that could be used in GYN procedure that could also be the same instrument used in a general surgery procedure. And we'll discuss some of those instrumentation once I get the instrument list and look at what set or the different sets that some of the instrument will be discussed. If you do have the textbook with you and look at table 15.1, that should be on page 513. You'll see a list of some of those instrumentations that are being mentioned. We'll review some of those here in a short minute. Now, if you're looking at OB/GYN equipment, those equipment are normally tailored towards the specialty in which the surgery is being performed. The location or the room will be designed to actually meet those requirements. Some of the things that you see is that the beds function as a normal facility bed, but they have foot ends that normally separates or drop down for delivery. These beds will sometimes accept one or more varieties of stirrups, and those stirrups are normally used to hold the legs of the patient, and other devices developed to accommodate the patient in various delivery positions, whether it's pathology or whichever other position that the surgeon or the attending or physician or midwife might prefer that patient to be in. Now, you could be lucky. You could see some of those beds could be electrically controlled, and some of those you have to do it manually. In modern days now, most of the beds are normally controlled electrically. What you have to do is you'll probably be able to break the bed into a 90-degree by folding out the lower legs and then attaching those stirrups on it, or you could manually remove the lower part of it and then put a stirrup onto it as an attachment. Now, gynecologic surgery requires the same equipment as abdominal procedure of general surgery. Now, since many of these procedures are normally performed with the patient in a lactotomy position, various types of stirrups and leg holder will be used. Likewise, the high percentage of laparoscopic procedure will require the surgical technologists to be familiar with the VD equipment, the insufflators that are normally used in this type of surgery, which are later illustrated, including these use like the laser that could be in it if they have to use lasers. Most of these supplies that would be required in chapter 15 has also been discussed or was discussed in the previous chapter in chapter 14. We'll talk about some of those here real shortly so I can show you some of those things. One of the things that you'll see if you have the textbook, let me pull this up so you can see. These are just different basic instruments. Every facility will have something totally different. Some institutions will have their vaginal prep set to have these instruments in there. The gray vaginal speculum, a 16 French urethral catheter for catheterization, a dressing forceps, a sponge forceps, just in case if they have to go down deep to stop bleeding or to actually see where the bleeding coming from. A solution cup could be also available and included, a deeper retractor, a vaginal retractors, Alice tissue forceps, alva with a speculum, a tenaculum forceps that could also be used to either grab the cervix or things like that. And then you have another one that you see going on is a vaginal delivery set. These ones could be included into now. It could be modified for other facilities, but this could be a typical vaginal delivery set for possible emergency surgery. Or if not, they will have this available along with a cesarean section to use them both to see what's going on. Now, the Kelly hemostat, medium needle holder, the tissue forceps, Russian tissue forceps, these are all pickups that you see. The placenta basin, that could be another one that you could have available in the room. Coil clamp to actually clamp out those coils before cutting, and sometimes this is the proper movement of the expected father. The cord blood tube that will also be used to send down. And then you have a dilation and curettage set that will also be available. A cesarean section set, just in case if there's an emergency that they have to attend to. And we'll talk about some of these cases here down the line so you can understand that, hey, when they're doing a vaginal prep, they're doing a vaginal delivery, what are things that the surgical techs and the nursing staff have to be careful of or mindful of or have to consider. If they're just doing a DNC, what's the purpose of doing those dilation and curettage? If they're doing a cesarean section, what's the cost of it? Why they have to do the cesarean section? Is it optional? Is it something that they want to do just for themselves, or is it an emergency? So those are some of the things that we'll be talking about. And a look at a basic vaginal set. You know, every facility, like I said, every facility is different. Their vaginal set might be different than what your facility might have. It just comes down to what your surgeon prefer, what do they have available, and what can they use during those surgical cases. And you have the laparoscopic set. Now, laparoscopic set can be used in general surgery as well as the gynecologic abdominal can also be used in general surgery. For the rest of it, normally tailored to GYN or to GYN surgery directly. A little bit of difference in that. So just be careful when you're looking at some of these sets. Not every gynecological set might be available to be used in a general surgery case. Now, can you get around it? You could, but most general surgery sets can definitely be used in gynecological procedure. Again, you have to modify and adapt some of those things because there are specific instrumentations that you will need and you might not have. So if you look at these surgical procedures, there's one specific procedure that only applies to multiple cases, one specific position, a little bit of correction. There's one specific position that applies to multiple cases. If we're doing abdominal cases, the ideal position for that patient to be in will be a supine position. That is, the patient is laying down flat on the back, facing upward. Okay. The other position that you also see is a lateral position. In getting this lateral position, it allows the patient to be comfortable laying down, and the surgeon or the surgical staff can manipulate the patient by doing multiple cases, or moving the patient in between cases. Like vaginal combination procedure, that will be something that you'll see happening for the most part. But those are the two common procedures that you'll see in GYN surgery. Now, I say this and I have to repeat, so I make sure I'm very clear on this, because this is some of the questions that you found on your CST exam. When it asking about a position that can tolerate or account or accommodate for one or two procedures. And the only position currently, the only position that can account for multiple procedures is the lateral position. Every other position can only account for one procedure. That's it. You're looking at beast chair for shoulder scope, same thing, just one. You're looking at how you call this thing for craniotomy, just one position. You're looking at oral maxillofacial surgery, just one position. But if you're trying to do two procedures in one position, the only position that can happen in is lateral position. You're probably working within the abdominal cavity or in combination with the abdominal, thoracic, and the vaginal cavity. Those are the only three areas that you'll see those things happen. And like I said previously, Trendelenburg will be another one that you can use for gynecological procedure, whereas the foot pedal have to be repositioned, moved, shifted to the left to at least allow visualization of the patient. So just keep that in mind when you continue to study for your examination. And when you're helping your nurse to position the patient in the room, there should be a specific session. Hopefully, every hospital should have a training on how to position patient without causing additional harm to the patient. Now, if you look at the anesthesia provider, their own availability of what they can do in the room is to help position the patient. They are solely responsible when reposition the patient. They are solely responsible for the head to keeping C-spine intact, and they will lead the charge to reposition the patient. The OR should be arranged with this mindset, with the mindset of anesthesia should be the one making the call, or whoever is at the head of the patient should be making the call for reposition the patient. Now, you should have a mail stand that will be frequently used by abdominal approaches. They may not be used for vaginal approaches. Sometimes you don't need a medicine, you just work off the back table. A back table, on the other hand, is an adequate size to accommodate the required instrumentation. Now, it all depends where you're working, which specialty you're in. You could have a bigger back table or a longer one that has a lot of room, or you could be unfortunate and have something very small and you have to manage it very well. Kick bucket, ESU unit, those are all things that you need to have within the operating room. But again, you just keep those things. Those are just simple things to have in there as you're doing your surgical cases. Let's see what else we can talk about since we stay here. If you have any questions, by all means, send those questions my way, or you wouldn't work on the feel free to interrupt me at any time and ask those questions. And I'll be happy to answer those questions for you. All right. Let's look at some other things. Doing the surgery is the surgical procedure for OBGYN. If you see, some of the things you see up here is for obstetric patient. One of the things that you will see is the patient normally exhibit normal condition. That would be for those different complications, no complication of pregnancy. Features of these will see routine visit, other things like that will actually happen. But performing these cases, you have to be very careful in some sense. Not you as the member of the surgical staff, but mainly the surgeon have to be very careful in making some of these decisions, whether to go open through a cesarean section or to allow vaginal delivery or nature to actually kick in through the process of vaginal delivery. So for obstetric patient, one of the things that you will see happening is that the patient will present an unusual situation in medicine. Whereas the patient now will sometimes exhibit a normal condition, whether it's a pregnancy. Now, if that occurs, you will realize, or you could see the patient seeking medical support and help because the condition, while it is considered to be normal, may have result in danger to the mother or the fetus. Now, care monitoring and diagnosis of the pregnant patient are something that normally begin with a physician office and normally require outlining routine process, routine medical visit. Now, at some point, what will happen is that the obstetrician now will perform surgery to facilitate or inhabit the natural state of the pregnancy. Now, when we all know what pregnancy is, so if that happened now, you're looking at a physiological condition that may have placed both the mother and the fetus in jeopardy. Now, this pregnancy brings a lot of different changes to the female body that normally presents condition that can lead directly to surgery, or it could somehow, sometime contribute to other conditions that lead to surgery. If this happens, surgeon will normally take a look and see what exactly they can do to mitigate some of these things, to prevent some of these things from happening, or if it do happen, how they can ensure safety for both the mother and the unborn child. Now, if everything works together well, through normal visitation to the hospital back and forth, patient could go into labor. Now, if there's a labor, if the patient is actually in labor now, the process of that labor is normally defined by 4 different stages. Now, stage 1 will normally initiate with the onset of true labor and is normally considered complete when the cervix of the expectant mother is fully dilated. If that cervix is fully dilated, well, patient is in labor, stage 1 has been completed. And now the patient body will transition onto stage 2, which will then complete the dilation of the cervix and then terminates with the birth of the infant. So those are the first 2 stages. The third stage will be a little bit different. It will be initiated with the birth of the infant and ends when the placenta is normally delivered. Now, that part is a little bit long, but really not much. The area that patient normally found most of themselves in for a long time to be between stage 1 and stage 2. And that will be the most critical and painful part for them. Well, for some of them. And to eliminate some of these pain, that's where anesthesia normally come in and see if they can give them some type of medication to relax them, but not medication to make to affect the fetus. So you gotta be very careful on that. Stage 4 begins at a point and is considered complete when the mother's condition has stabilized. The length of each stage is highly variable under normal conditions. Now, there could be many different factors that could contribute to the length of that. Other factors could be if this is the very first pregnancy that a patient is experiencing, stage 1 could take way much longer than if it's the second time experiencing that pregnancy. So it all depends what might go on in there. But those are just some of the things that you have to consider when you're doing most of these things. If everything goes well, patient goes into into stage 1 and stage 2, they can have a normal delivery, and that could be vaginal delivery that could occur. And if for some reason something went in a different direction, now we have to look at a different alternative. It might not be a vaginal delivery anymore. It could be a cesarean section that might occur, and it could be considered an emergency procedure. Now, when completing some of these delivery, whether it's vaginal delivery or not, middle vaginal delivery, when considering that there are specific instrumentation that has to be used. And these are some of the instrumentations that you'll probably come across or you'll be familiar with. You have the delivery forceps that could be used both ways. It could either be used for vaginal delivery or they could use that in cesarean section. The Kila, the Dilly, Lenka, and the Simpson, those are all instrumentations that you see. You can also, or you will also have a vaginal retractor, which is this one you see right here, will be inside. Now, one of the caution you have to use, or you as part of the surgical staff have to be very careful, is when this vaginal forceps is going in, have to be very careful, the vaginal retractor. When it goes in, it has to be closed. When it's coming out, please make sure that it's closed, because if it remains open and you try to pull it out, that can actually hurt the patient. And you have another one, the Graves vaginal speculum, will be this one you see right here. Happens to have just one end. You can use this tape to actually use it as a retractor or pull it down. And then you have another one that will have two areas. The Sens vaginal speculum could have two different areas. That would be the vaginal speculum double end. The Sens vaginal speculum. So the Sens vaginal speculum could be one or two. You could use both ends. You could use one end for one, or use the other end for. So this could come in one size, or it could come in two. And then you have the upper water vaginal. The upper water vaginal speculum is almost like a self-retaining retractor that you just insert and just let it hang, because it's a little bit heavy, it has a little bit of pressure on it, so I can pull it down. Now, when these things going on, the normal rule for surgical technologists is for most delivery in a natural and a normative pattern, the surgical technologist is there as part of the team to assist. Now, they could support the mother, they could prepare for development, for developmental problems. It is also common that they could help with clamping and other things like that. But in the vaginal delivery process, the need for surgical tech is pretty much obsolete. You are just there just in case the patient condition changes. If that happens, the fetus is in distress or something, they can convert that vaginal delivery to cesarean section. That's the time surgical technologists will be able to come in. Now, there are also many different instrumentations that you'll see in GYN procedure. You have the cervical and intrauterine instruments. You have the Goody uterine dilator. You have the St. uterine sound, the Bozeman uterine dressing forceps, the Hagar uterine dilator, the Schroeder's brain uterine tenaculum, the St. retractor, and of course those different curette. This curette is just one curette, but they have different sizes that goes in the script, the uterine wall. This tenaculum will be able to grab the cervix and manipulate it. You have the measuring device that will go in and actually measure the depth of it. And you have the Goodyear uterine dilator That could be another one that you could see in there. The dilator is this one, and you also have the Hagar uterine dilator. All of these things happen to have different size. You have this one to go in first to determine how the patient is dilated, and you need to make that dilation a little bit wider to create more space. You can then go to the Hagar uterine dilator. You have the small size here. They could be size 1, and the other side could be size 2. As you can see, it might be a little bit smaller, and you can see clearly. So this could be 3, this was 4, 5, 6, 7, 8, 9, 10, 11, 12. That's a guarantee you get to the actual dilator that you want, or the actual diameter you're trying to get to. Now, on your exam, some things that you'll see is you'll either see the picture of the instrument that will be given to you, and you have to identify what kind of instrument is that, or you could be asked, so a blank instrument was used in this procedure to perform XYZ, and you have to know whether that instrument was a retractor, or maybe it was just a pickup or a forceps or a hemostat. You have to know which one is which. But those are basic things for you to know later on. Now, abdominal and perineal retractors. You'll see some of these ones right here. All of these, they are abdominal perineal retractors. They can be used within the perineal area. It can also be used within the abdominal region too as well. You have the Diva blade. Normally it's like 2 in 1. And you also have the D-lead universal retractor. The D-lead universal retractor is just when you have a Diva blade. These two you have. And then the other thing that you do have is the Gilpey perineal retractor. Yes, it's called Gilpey because you look at these two ends here, it's very sharp. Instead of pointing inwards, actually pointing outward. And this is considered a self-retaining retractor because of the ratchet you have here allow it to lock in place. As you continue going on, you have the O'Sullivan O'Connor abdominal retractor and the Balfour retractor. When cleaning or maintaining these instruments, these retractors, you have to account for every part. And during the surgery, especially for abdominal procedures, you have to account for every single part of this retractor. O'Sullivan O'Connor retractor, and this is the Balfour retractor. Have to account for all these blades. All different instrumentation that's being used. Now, other thing that you'll see moving forward is this wonderful retractor that you see here. Almost the same, but it is a little bit different from the Balfour retractor. The thing about it is the Fence abdominal retractor, or the interchangeable with the interchangeable blade. The thing that's different with this one is it depends on the size of the patient and the surgical incision side to see whether you want to use this, or if you want to use the Balfour retractor. Okay, they are, again, a lot of different things has to be considered. The organ you're trying to get to, the size of the patient, the incision side. Those 3 things can be very, very different in making selection on what type of retractor to use. And of course, you have your needle driver. Happens to come in different sizes, whether it's long, short, small. You have the scissors. You have your let's see, this is your Jensen scissors that you see where it happens to have this curved end. Your Mayo scissor, dissecting scissor, will also be used for dissecting. Now there's also another one called a Mayo straight scissor that will be directed for suture cutting. But with this one with the curve, that'll be used for dissecting those tough tissue or tough muscle. That's what that will be used for. Other things you have is a needle holder. You have a needle holder right in this area, and you have the things going on for you. But you have a lot of different instrumentation and additional ones that you also see moving forward. Excuse me. So a lot of different instruments you have to be familiar with. There's nothing that setting stone that says that you have all of these instruments. The handling hysterectomy clamp will be used in GYN surgery. But again, just one of those things, you have your pickups that you see, your Ferris Smith Russian pickup, those different ones. Ferris Smith Russian are all down here. These are different. These are some of the most common instruments you see not only in GYN set, but also in a general surgery set. definitely you will find the hysterectomy claim in the GY insert. That you will see in there. The Henry Valentine hysterectomy claim, which is this one here, will also be in the GY insert as well. So you have a lot of different ones. But those are some of the simple instrumentations that you will see in GYN surgery. Now, other things that we'll talk about, we won't talk about all of these things, but it just shows some of the things that you have to consider. Key terms in labor and delivery. Just tells you a lot of different things, common features of obstetric examination, what are things they're looking for in doing those examinations. This is done mainly by the surgical staff. They will do these things, what they do in the physical examination to know this speculum that is being used. Because the speculum, again, like I showed you, normally have two different sizes. Not the speculum, rather. The speculum, like I told you, when you're putting it in, you have to make sure it's closed. Then when you're taking it out, you have to make sure it's closed. Because if you don't do that, you'll hurt the patient. Have to make sure that the cervix, you can measure the depth of it and all these different ones here. But those are just some information for you to see in your textbook as we continue on. We already talked about the labor process and the stages. So you have 4 stages. Stage 1 might be different between first and second birth. Stage 2 could go all the way up to the child is out. Stage 3 could see the delivery of the placenta, and stage 4 could see the recovery of the mother. Normal rule of surgical tech, we already talked about it. We said some of the things that could happen is in vaginal delivery, you just stand there and wait until they need you. And if they don't need you, well, you have and do something else. Support the mother as much as you can. Other things that you'll see in the vaginal birth that could happen is episiotomy. Now, what that means is that during the birth canal, there could be some laceration or some vaginal tear from the pushing. The birth canal might not be wide enough, or the vagina might not be wide enough to account for the passage of the fetus. So if that happened and the patient is teared out, what will happen is that they could throw in 1 or 2 stitches in there, or the stitches they could put in could depend on the length and type of tissue. These are questions that are normally asked by the surgeons to the mother before she gave birth, to say, hey, there could be possibility that there will be a tear. If it happens, you want us to be prepared and get to answer some of these questions before they can continue on. And if you don't, again, they'll make a best judgment. If you say no, if there's a tear, you refuse to acknowledge that to be closed before you actually deliver it. If they see that, they will make a judgment call to make sure they're doing the right thing for you, not just you, but also for the patient, rather. I'm sorry, not for the fetus, but for the patient. Because sometimes you might not know what's going on, and you just want things to be done the right way, and you want to get out of that. So people give information without knowing what the final outcome is. Now, episiotomy. So this is an intentional midline surgical incisions in the vulva. When it says intentional midline surgical incision, what happening is sometimes things that will happen in vaginal delivery is understandable. There could be some tear, there could be some laceration, okay? That can happen naturally. In other cases, these laceration or tears will not happen naturally. That's something that the surgeon on call or the midwife or whoever doing that delivery might have to do something to make sure that there is no harms to the fetus. And that could be, they have to go in and make some type of surgical incision, something quick to give rise to the child to come out. And if that happened, that would be considered episiotomy. Now, it says a surgical midline because they try to make sure that they don't create any type of cosmetic failure. So when that happens, you'll see after everything is done, the child is born, they'll go back in and then try to put in a couple of stitches. There are some classifications that's done for this type of laceration that's occur or surgical intervention, I will call it. Now, Both surgical episiotomy and perineal laceration are classified according to the depth of the wound. The common use definition are normally found in, if you look at a textbook, you'll normally see a table that will have most of the common definition. You have first degree, second degree, third degree, fourth degree, almost like burn. Classification is normally based on the burn category. Page 522 in your textbook will tell you what those things are. First degree involve the vaginal mucosa or the perineal skin. That's nothing, okay? Second degree now will extend into the vaginal submucosa or the perineum with or without the perineal body, the musculature and being involved. The third and fourth one, you're looking at the inner sphincter and the rectum mucosa. Now, we don't want third and fourth. First and second is okay. If third and fourth do occur, you have to throw in a couple of sutures in there for repair, just to make sure patient is okay. But that's one of the things that you see from childbirth during vaginal delivery. Things happen, and we just have to adapt, overcome, and make sure the patient, because then we have to account for two patients, make sure both of them are doing well. Moving on. Other procedures that you'll see in OBGYN surgery is a little bit different. A lot of different procedures. We'll be talking about cervical curettage. Other people might refer to it as cervical cerclage. You have cesarean section, tibial sterilization, or the reversal for tibial sterilization could be a tiboplastic. You have laparoscopic resection of unruptured tibial pregnancy that could also be done in there too as well. And we'll talk about some of these things here shortly. Cervical cerclage. Other people, well, this one also refers to Chareki procedure. What will happen with procedure like this is some other thing. I mean, we have to consider some things to happen. But what we do with this type of procedure is we'll go in, if looking at the anatomy structure or the anatomical structure. Other things that you'll see looking immediately at the uterus. We all know that uterus is a hollow organ. It has a thick wall. It has some type of shape. It's a pear-shaped organ that's normally situated between the bladder and the rectum. The midline portion is the body, and normally the superior portion, when you look at it from the frontal view, is normally called the superior portion of it is called the fundus. The fundus is that big one that you see that'll be on the upper part. See if I can show you a picture here shortly. The body narrows to the lower portion coming down. Just look up here and then you see. If you look up here, the top part of that pier, that will be considered the fundus of the uterus. And then coming all the way down now is a little bit shaping coming down. And you will get to see the cervix and how you call it, the external OS and all these other things. But just a typical anatomical landmark to share with you, so at least you know what we're talking about. Now, this uterus is held in place by a lot of different ligaments. Okay, you have ligaments holding it in place from it being suspended from upward, and you have ligament holding it in place to actually get it surrounded by the sacrum. So all the things kind of right in place there to make sure that the uterus is not just hanging and nothing holding it up. Those ligaments are responsible to hold it in place. But some of the things that we're looking for diagnosis and testing, normally use an ultrasound to reveal some of the abnormal things that they're looking for. Whether the fundus is short, the cervix is long, or other things like that. But that'll be done by using the ultrasound. Equipment that will be needed will be a DNC, dilation and curettage, or basic vaginal instrument set, which I just show you that instrumentation in there might be a little bit different based on your facilities. Cervical cones of various sizes. You could see disclaim ligature carriers. Some might even ask for a 5mm diachrome or Mercedes tape to use. After the procedure, a lot of different things could happen, but we'll talk about the post-procedure part on what to consider. But before the patient comes in the room, looking at pre-operative preparation, things that we're looking for. patient has been diagnosed, they know that, hey, all these things that happen, we got our diagnosis, we're going to go in there and then perform a cervical curettage or cervical cartilage. If that's the case, what we're looking at is how can we take care of this patient? Patient comes in the room, patient have to go into a latotomy position because now we're dealing with the vaginal area. We need to have the patient legs up in stirrups, and to do that, we have to either remove the foot part of the bed or we have to break the bed to 90 degrees and then attach stirrups. Anesthesia provider will put the patient in a supine position first, so they can administer their anesthesia and all these other things. In some cases, they'll probably give the patient epidural to ease some of those things. Other things that you see, the patient's skin will be prepped, but before the patient's skin is prepped, patient will already be in the latotomy position. So the first position the patient will be in during the procedure is patient comes in, will be in a supine position until they can intubate the patient. Once the patient is intubated and everything else under general anesthesia, the next step now is to put the patient in the surgical position for that surgery, and that will be the latotomy position. Right after that, safety strap, everything good, have already done the TAMES test and the timer for all those things. Our vaginal prep will be done. Prep will be done in the circular motion, including the inner legs. And then right after that section, now you have a draping will be done by the surgical staff. Procedure will be performed. When the procedure is performed, the cervix will be dilated, and those dilators I show you will be used for the dilation process. Now, this will be considered a clean case. However, we have to treat it as sterile as much as we can. The vaginal preparation must be carefully performed to so that it cannot be disturbed. The surgical procedure itself, you will get either whether a vaginal speculum will be used posteriorly into the vagina, and a diva retractor will be placed anteriorly. Now, all of these retractors are being put in there is to make sure they happen to have a visualization on what they're about to do. Things that you have to consider from the surgical tech perspective would be to hold the diva retractor in place. And of course, sometimes the surgeon and the surgical technologist will be working off the back table. So there's a good chance that you probably will not be providing instrumentation, you probably be helping. The surface is normally grabbed, and when that surface is grabbed, you have a sponge holding forceps, which is the sponge forceps will be used to pull downward inside the vaginal vault using long, smooth tissues forceps. The long curved maxibone scissor could also be used to as well. The cervix will be lifted anteriorly, and the forceps with the forceps, and posteriorly, the posterior vaginal mucosa is normally incised. All of these things will be done with that procedure. A couple of things that you have to pay close attention to is what position the patient was in, what kind of prep was done, and what kind of suture will be needed to be used in this case. Now, once it's all done, patient have to be closed up. Mucosa that was incised will be closed with a 1 or 2 or absorbable sutures. You have to know what kind of sutures is being used where, because you could get questions pertaining to that. You have to understand one other thing, the wound classifications. That could be another tricky area for them to get you. Now, because this is a clean case, it's not going to be a class 1. Class 1 will be a little bit different. So we can consider this to be a class 2, which is clean contaminated, because again, the location, all the mucous membrane are considered dirty. So that would be considered a dirty, well, a clean case, we call it. We try to make it as sterile as possible. So this will be a clean contaminated procedure. And the other procedure you have is a cesarean section. Now, for this cesarean section, one of the things that you see, again, the same anatomical position that was used, or the anatomical structure that we just discussed in the first procedure, everything still applies here. History and physical will be taken to as well. The feeder and the maternal monitoring will be done during the labor process, and that will determine whether we have to do something totally different. Cesarean section, back table have to be set up. You need to have above 7-inch, a cord clamp, all these other things. Now, in the true emergency, the expectation for you to have all of these things ready and from this onset of things will be impossible. The two things that you need mainly is once you open your back table, you need to make sure you have a knife blade ready to go. The next thing that you need is you need to have some lamps ready to go. That's it. Those are the two major things. The rest of it, you can take your time and get those things in there after the case is on the way, or if time permits. Again, patient will be in a supine position, and one of the things that they'll do is they'll put a roll under the right hip to reduce some type of uterine pressure of the vena cava, because you don't want the patient suffering from some type of blood loss or trying to have the blood to stop from going to one place. So that roll will be placed in that area. They could use a spinal or epidural preferred. Now, the thing about epidural is it will just paralyze the lower extremity. You don't want to give medication because the medication could sometimes slow down the heartbeat. And of course, you don't want that to happen to the child. So they'll try to prevent those things from happening. Patient will be prepped, and again, the same position is how laparotomy will be used to as well. Now, because there's a C-section, patient will be in a supine position, but the draping will be a laparotomy draping that they will use. C-section is considered an emergency case, but again, it could be considered emergency. Other people might consider it to be an elective case. 10 blade will be available to use. Once you go through the fascia and everything else, Gala or US Army Navy retractor is one of the most common one that will be used in there to make sure that the patient does not stay too long under any type of medication. Sometimes the patient will be awake while they're performing this procedure. And of course, in that same room, they will have everything available. You have a special team to care for the fetus. The placenta will be taken out, sending somewhere else. But again, there's something called placenta preview. If that happens, that's a different surgical procedure that we'll talk about here if it comes up. But those are some of the indications that you have to be very careful of if there's some type of concern about placenta preview or placenta eruption, different ones. So other hospitals have a labor and delivery area that can handle everything. Some people will have to transition that patient to a different location in the hospital and say, hey, if this happened, we can do everything here. But things that you have to consider, or the team have to consider, is other diseases that could be in the cardiac disease, diabetes mellitus, cervical cancer, all those things. That have to consider those things during that period, just to make sure that the patient and mother are both okay with no problem. So the procedure will go on once everything is done. One of the things that will happen is to do that closure. Patient will be closed with some suture, again 2O or some type of or absorbable suture that will be placed on the uterus just to close it out, and the uterus has to be closed in the same layer that it will open up. If there was any problem with the bladder, you have to check the bladder to make sure that there's no perforation or penetration within the bladder. If there is, that will have to be repaired before the patient is out. Now, the distinction between a cesarean section and a cervical cerclage is that cesarean section is considered a sterile procedure. So it will be a class 1 because we're actually making phalangeal incision on the lower abdomen of the patient. So we're not going through the vaginal wall. And since that is not a mucous membrane, it will be considered a clean case. But we'll have to be ready for, how you call this thing? We have to be ready for some type of post-surgery surgical complication just in case, or some type of surgical site infection, which can be prevented too as well. And then you have tubal sterilization. Tubal sterilization is very simple, very quick and easy. Anatomical structure same as we discussed previously. But what we're looking for is individuals like these are either, the reason why they'll probably do things like this is 1, they no longer want to have kids, or 2, there's probably some type of cancer cells growing somewhere and trying to isolate it and get it out. So that could be done. It's very quick and easy. Use a laparotomy or laparoscopic set. It could be done laparoscopically or it could be done open. Now, other cases where they will perform C-section, patient can also choose to have tubal ligation done in conjunction with the C-section, and they can just do everything right in there. It's just a surgical interruption of the tube. Go in, cut the tube, tie it up, and make sure, just to make sure that eggs and all these other things are not able to be sent back to another place for reproduction. But A lot of different techniques to use, and it looks a little bit different. In your textbook, if you look on page 530, 531, you'll see more information pertaining to that. The wound classification for this will be considered a class 2, clean contaminated. Now, it will be clean contaminated if manipulator were utilized, but if not, it will be considered a class 1. Depends on the location where they did the procedure. Tuboplastic is the reverse of it. Same anatomical structure. 2-hole suture will be used for this one, but what will happen is patient decided to come in and say, hey, I wanted my tube to be tied. And then 2-3 years later on, they say, no, I really want to conceive this time. Tuboplasty will be done to go back in and surgically repair the interrupted fallopian tube, to go ahead and open it back up and and join it back in and see if the patient will be able to see. Now, this will be a microscopic type of procedure, so there's a good chance that it could be using a microscopic equipment or some microscopic instrumentation to get a repair done. Suture-wise, suture could be a little bit different. Patient will be in a supine position with general anesthesia. A lap drill will be used. Patient will be prepped to as well within the abdomen area, and they will make that decision to go from there. Another way to do tuboplastic is patient might not even have how you call it, a tubal ligation. They might have something going on their tube and they want it to be removed, but they still want to reserve their ability to conceive. So they'll go ahead and have that unwanted section of the tube removed and then reconjoin it or kind of like reconnect it to go on from there. Sutures, patient will be off about 4 to 6 weeks, but it should be good to go. This will be considered a class 1. The suture that are being used here, instead of using a 2-0 suture, which will be done at some point, but it'll be using an 8-0 and a 9-0 as opposed sutures, because those are very small. And since they're reconnecting things, they want to make sure they have everything in there successfully. Other things that you also see is besides tuboplasty, you have laparoscopic resection of an unruptured tubal pregnancy. So same thing, same anatomical structure as before, but what happens is that this procedure can occur in the fallopian tubes, mainly the ovaries or the cervix or even the perineal cavity. Some of the common causes are physiological. It could be a physiological interruption of a normal mechanism for transport of oocyte and the anatomical changes to the fallopian tube. So at some point, what you'll see is that the oocyte were being transported from one end to the next to get fertilized, but for some reason, fertilization never occurred in the uterus. It actually occurred within the tube, and that start causing problem. It could be considered ectopic pregnancy. If that happens, yes, they can go in and perform this procedure on ruptured tubal pregnancy, can go in there and fix that, and that's what this is done for. Patient will be in a lactotomy position too, of course, but some cases, surgeon might prefer having the patient in a slight Trendelenburg position, at least by 15-degree rotation. General anesthesia will be preferred abdominal, including the vaginal area will be prepped to as well. A drip will be implied onto that. Now, surgical technology should anticipate a large volume of blood loss in the abdominal cavity, and this will be due to hemorrhage. So 2 suction setup will probably be nice, unless of course you're using a Neptune machine, and in that case 1 suction should be okay to consider on that. But a couple of consideration to focus on the side of the tubal pregnancy is it has to make sure they confirm the visualization of the diagnosis before they can do anything else. If that is done, they can pass on the electrosurgical instrument through the access port, and then you can start using the laparoscopic Babcock to start checking patency and other things like that during the case, just to make sure everything is being done accordingly. At the end of the procedure, the wound classification will be considered, it will be down to wound classification 2. That's what will be placed onto into the patient record because of the surgical procedure that was just performed. But the patient will be closer and categorized as wound class 2. The sutures should be passed and count. You definitely have to do count just to make sure everyone is on the same page and singing the same music, they're playing to the same sheet of music. Those are some of the most common and typical procedure that you see in OBGYN surgical specialty. Other things that you also come across is the surgical procedures, other symptoms and other things like that are happening. In gynecologic surgeries on the female reproductive system, common features of GYN examination. Other things that they could be looking for could be a little bit different. Contraceptive history could be one of the things that we could be pushing out. There has to be a complaint. The patient need to come in and say, hey, so and so happening before they can start doing other things, just to make sure they observe everything. Physical examination have to be done. A laboratory test has to be done too as well. And some of the laboratory tests will focus on urinalysis, complete blood count, erectocide, blood chemistry, and other things, just to make sure they get a full understanding during the diagnosis process of the patient. Now, they could also be looking for benign lesion of the vaginal area, just to make sure there is no cyst or nothing of that nature in there. If there is, they can identify and then see if that can be done without surgical intervention. If it's not, then surgical intervention will be warranted for it. Select gynecological conditions, symptoms, and diagnostic tests. If you look at your textbook, you'll see most of these things in there, but there's nothing really to go over because it's not going to mean anything for you, because these are just diagnosing the patient. Dysfunctional uterine bleeding. If the patient having condition like this, what will happen is, especially this normally happen, like some of the signs that they'll be getting will be during the time of menopause. And some of the typical diagnoses that you can use is either they start smelling walked away or rule out other causes. And the rule out other causes, you have to do a CBC count, you have to do a platelet count, you have to do coagulation status, you have to do a thyroid function status, liver function status. Now, you have to start small, and if none of those things actually working, you got to go do a hysteroscopy and see what's going on, or eventually do a DNC. Maybe taking out all the uterine wall and letting it to resurface itself might help out in that process. But you start small and then go all the way up and build over it. The same thing with uterine cancer and cervical cancer and ovarian cancer. There are stages that you have to go through the diagnosis process, just to make sure you have everything you do need, or you want to make sure you address everything at a lower level possible before you take drastic action. Other things that you'll see is the summary information. Excuse me. All of these procedures that you do see, some of the things that you come across is the vulva and the vagina and urethra area. So summary information just provide everything in a lumps, in a compacted environment, but nothing major in this area for me to go over with you. You can definitely review it on page 542 if you need to. Abdominal incision for gynecological surgery. Some of the different incisions that will be made can be made to a lot of different places of the of the body. But some of the things that you'll be looking at when we're doing these incisions is transverse abdominal incision that will be used. You could see appendiceal incisions. It all depends what you plan on doing. Even a laparoscopic one could be done, whereas you just using some type of air and knife blades to do a laparoscopic case on the abdomen. So it all depends what the surgeon is looking for and what will be the best practice for it, for that case. Vertical and oblique. All depends again. This comes down to what location, what they're doing, what kind of procedure they plan on doing, to then decide, okay, well, maybe we should do vertical incision, oblique incision, or transverse incision. It all depends. Incision normally used in GYN, gynecologic and abdominal surgery. Now, this incision falls into three basic categories. Those three categories is what we're just talking about: transverse, vertical, and oblique. Now, one of the things you have to consider is that the transverse incision provides the best cosmetic result. And the thing is, they are nearly 30 times stronger after repair. So this is something that surgeon will have to keep in mind when performing those incisions, because one of the things they consider is that for the transverse incision, they are relatively more time consuming and hemorrhagic than the vertical incision, even though the time consuming is also strong. Now, the transverse incision can compromise nerve, generally involved in the division of muscle, and they may sometimes limit access to the upper abdomen. You have the vertical and the oblique incision. This one, chapter 14, we talked about it not too long ago. Transverse incision in the name, well, they are normally named for surgeons who originally developed the technique. The three most commonly used ones that you will see for transverse incision, one of the most one used in GYN is the Fenestier one. Other one will be the Midland and the Shannon incision. Those are the three most common ones that will be done. But when these things happen, to close this incision, the closure of this incision commonly begins with the fascia with a running number 1 or number 2 for the collegiate suture, because you need something big to hold the things together. Because the body parts that I just went through, and they don't want it to kind of tear up too much, so you'll be using that. But those are some of the sutures, and some of the sutures that you have to keep account of: number 1, number 2, 80, 90, 20, 30, 506, especially when you start looking at ophthalmology, optometry surgery, some of the different ones. Diagnostic procedure will probably require just you having a basic laparoscopic and a hysteroscopic set. And what will happen is these one will be used. They have been used over the years to help diagnose some of these things, or advanced modern technology. The procedure can be used for diagnostic and some type of interventional purposes. If you look at it, some of the things that you see on for the procedure for a basic laparoscopy set. Of course, the patient will need a history and physical that has to be done. You have a major set that'll be required. Patient will be in a lateral position, or sometimes they'll probably have in a slight Trendelenburg position too as well. While they're under general anesthesia, we have to check and make sure, or surgical techs have to check and make sure all the equipment prior to the patient entering the room, because you don't want the patient being in the room and things not going well. So you need to make sure you have a towel, you have a CO2 monitoring device, you have the camera system in it too as well, the scope. You want to make sure you have all the things, the right sides of the camera, there's a light source. You want to make sure you have all these things ready, along with the choke cards, before the patient can come in the room. And then once they come in, try to have a lot of different camera scope, on whether it's 520, 530, 0-degree scope, whatever the surgeon want to make sure you have at least enough in there so they can be able to see what they really want to see. This procedure will require number 11 and the number 15 blade. The 11 blade will be used to kind of puncture through the abdominal wall to get in, and then introduce the CO2 into the abdomen to put some air in the patient. Once everything is done, the procedure is done, and everything else, they will take out the CO2 out, and then they will just close those incision port. Wound classification is considered to be class 2, clean contaminated, only because at some point when they're performing surgical procedure like this, they will be manipulating the uterus through the vaginal opening. So going back and forth, that's why the classification will have to be a little bit different. And then for another diagnostic purposes, if they don't use the laparoscopy to do that, they'll do a hysteroscopy. And hysteroscopy too as well is the same thing as before, the previous one, the laparoscopic one. History and physical will be done too as well. You need a DNC, dilation, and curettage instrument set. So if they do go in and they see something, they can just stay in and perform a DNC and move on. Patient position will be the same. Laterotomy with general anesthesia. Vaginal prep will be done too as well, while accounting for surgical site infection. Once they are done, patient will be closed up, and wound classification again will be class 2 because of the location that they are working in. Now, Extended procedure that could be done in GYN will be considered the myocephalization of the Barthold's gland 6. Now, the gland kind of sitting out, if you look at the location of it, is pretty much the greater vestibule. You'll see two glands that are located in the posterior third of the labia majora. Those are the glands that will be talking about. It normally secretes mucus and provide vaginal lubrication. So they are not really going into the vagina itself. If you look at labia majora and labia minora, this one says that the location of it is the labia majora. The majora, so they're just staying on the outer surface, not even going towards the labia minora. So it's just the outer surface within the vulva. Now, while they are in there, one of the things that they'll be doing is they'll make sure there's a well examination that will be done, vaginal instrument set, drain of the surgeon preference will be used, whatever drain that the surgeon wants. Aerobic and anaerobic culture too will be sent down just to make sure they capture what they need to capture from that patient being in a lithotomy position. You can do this on a local anesthesia. If not, if they don't do local, then they will just put the patient on general and they just go from there. This one procedure does not require hospitalization. Once the patient is done, the patient could be released to go home the same day. The only thing about this other procedure is that classification of this one could be a class 3 or class 4. It could be dead or infected because if something happened to that gland and they have to drain it, well, you have a pulsing that they have to take out, a priogen. That priogen have to be sent down for diagnosis, so definitely be class 3 or class 4. Now, if there was any incision that was made, that incision cannot be closed. That wound will have to heal from the inside out. So we consider a dirty wound. Simple vulvectomy. So simple vulvectomy and ablation of the condylomata. If we're looking at this procedure, what we're talking about is we're focusing our attention on the mons pubis to characterize the mons pubis. Now, there's something that could be a slight elevation that is normally anterior to the syphilis pubis or syphilis pubis, and of course superior to the vaginal opening. If you look at the labia minora, you have those two flat folds, right? Now, think about opening those two flat folds, and then you'll see what's going on right in about labia majora, right? That's why they'll be working. Now, MRI could be done. They could do some CT scan just to make sure, but for this one, you probably need just a basic vaginal instrument set, a urinary catheter. You'll be sending some cultures down to as well, so you need some of those tube, aerobic and anaerobic culture to go down. Patient will be in a lithotomy position, like always. Again, for GYN cases, primary position is lithotomy. Dripping procedures stay the same. Consideration had to be placed the prep to pass the hemostatic instrument. You just have to consider where you will have to pass those instruments because you don't want to contaminate the instruments in there back and forth to field, even though it's a clean, it's a dirty case. But you just want to make sure you have those things in there. But it could be a simple vulvectomy. If you see a simple vulvectomy being performed, what they'll do is they'll just go through the skin. The pinnacle arterial ligament will be cut out. The closure of the levator anterior muscle could also be done too as well, and a catheter can be placed in. But these are simple cases for GYN, nothing complicated. Case will be considered as a class 2. Healing process now could take anywhere from 6 to 8 weeks for the patient to be able to walk around as comfortable as they can be. For the ablation of the carcinoma section of it, one of the things that you see is that either there has been some type of external genitalia wax, usually spread by sexual contact. This one is kind of like similar to vulvectomy, procedure as far as the anatomical or pathological history and physical preoperative process goes. We have to make sure that there's a preservation of the vulva and other external genitalia structure. Okay. Now there could be a specialized mask to be used, like the N95 respiratory mask to be used in here. They could also use a CO2 laser. You just gotta make sure the surgical puma is evacuated with care to prevent viral transmission. So cases like these ones, I have to make sure that you have the right mask to be used in it. Next one you see is a labiaplastic or labioplastic, whichever way you would like to enunciate that. It could be either labiaplastic or it could be considered as a labioplastic. Surgical procedure as far as anatomical structure will be the same as the rest of them. Laser could be in the room if the surgeon wants, patient will be in a lithotomy position. Some people try to do this on a local, but they are crazy. Definitely general anesthesia will be preferred. Bleeding, yes, it's always a challenge when labiaplasty is being performed to control bleeding, but at some point you can try and do that. Technologists, the ST will be responsible for suctioning and spooning the surgical site to aid the surgeon. So yeah, you have, because of the bleeding partner, you have to make sure that the place is a little bit how you call it, clean out for visualization from the surgeon. So if it's just you and the surgeon in there, you could be helping with other things, whether it's suctioning or making sure you have great tests available to clean up some of those blood. Now, once this procedure is done, there are 4 techniques for labiaplastic. One of the techniques will be the amputation part, where they will focus on putting the clamp across the area of the labia tissue to be resected, and using the scalpel by the surgeon's excises and tissue, which is then sutured back together. You have the central wedge. The central wedge will focus on resection. You also have another one will be considered a Z-plastic technique. A Z-plastic could be done too as well to take care of that. It just depends what will provide easy outcome for the patient. It will be a class 2 type of wound. Prognosis on this one, in about 1 to 2 days, patient should be able to walk around, return to normal duty. I don't know why they will have a labiaplastic. Everybody kind of like a little bit different. So they do whatever they would like to do. Other thing that you see is a technique called de-epithelialization. This one is described. If you look at this sort of procedure, it can be performed with a laser, right? Whereas and then you have clitoral underholding is another one that they will do for labiaplasty too as well. Just different technique that they would like to use. And then you have the very basic one, DNC. DNC is a little bit different. One of the things they're looking at when you're looking at sepulchral surgical procedure and trying to understand what's going on, dilation and curettage would be one of the procedures that they will perform. That is normally done for diagnostic purposes, and then they can go ahead and go from there, especially when IED is normally lost in the patient. They try to find it, they'll go ahead and take a look. If they can't see it, then they'll just kind of like clear out the inner lining of the uterus and take pretty much clean everything out. But there's a specific technique that has to be done when they're doing this. Because of blood and other things like that, there will be a specific technique that has to be done, especially when putting in different steps, rather. Diagnosis is normally obtained by history and physical. Vaginal instrumentation will be done. DNC set will be required. TEFA for specimen will be required too as well. Water soluble lubricant will be required because of the insertion of the dilator. Anesthesia normally general. Patient skin will be prepped and dripped. We're looking at vaginal area that will be prepped. If they can do a sonography, that would be awesome. If not, we'll just continue on. The pelvic will be examined to determine the size, shape, and position of the uterus, and of course to detect any masses that may or may not be in there. An oval weighted speculum will be placed in the posterior vagina and tucked under the external OS of the cervix. That is very important that it goes in there, because that'll be the first step in this procedure once the dripping process is already done. So you have your suction tubing, your suction curettage will be in there. Uterine sound will be inserted in once you have that oval with a vaginal speculum will be in there. The uterine sound will be inserted just to start the dilator process, and then you start using your dilators. While you're doing that, before you can even insert the uterine sound, you'll use the tenaculum to grab the cervix. So the oval with a vaginal speculum will be placed in first, The tenaculum will be used to grab the cervix, and then the uterine sound will be used to actually measure the depth and everything, and then start the dilation process before they start entering the dilator. Once they reach the ideal depth that they need to be in, they can then start utilizing the correct, starting from the smaller size and working their way up to the larger size to make sure they capture everything that they do need. If for some reason they need to get some tissue sample out, other things that will be done to us where you have a punch biopsy that could be used, a testicular biopsy faucet that could be used, or maybe a tissue specimen can be pulled out and sent over to laboratory to see what exactly it is that they have. Wound classification will be a class 2. Again, patient will be able to leave and go home the same day, and they could be able to walk around too as well with no apparent problem or no issues. All right. And now, with that going on with DNC, it takes us to oophorectomy. Understand the definitions of these surgical procedures, right? Oophorectomy will focus on ovaries. Now, the ovaries, they are normally oma-shaped structure that lies on either side of the uterus in the ovarian fossa of the lateral pelvic wall. The ovaries are normally supported by ligaments, a fold of peritoneum arising near the overlying membrane forms the suspensory ligament, also called the infundibulum ligament. The ovarian ligament lying in the broad ligament provides the main support of the ovaries. So it's just an anatomical structure. But what this procedure is that, hey, something is going on with the ovary, they have to take a look and see what is going on, right? And that's what the procedure will be performed for. Indications will be there's some type of oophorectomy, and ovarian malignancy, or some type of cystic disease that's kind of like strangulating or strangulating the ovaries, infection, adhesion, or it could be some type of endometriosis. Now, some of the things that you need after you do all the tests and everything else, you will need a major laparotomy set. Patient will be in a supine position with Streicher-Denenberg. General anesthesia will be administered. Skin will be prepped. The abdominal area will be prepped. The laparotomy is performed. The ovary is identified. Most lap sponges placed around it to normally contain any spillage that will come up from the cyst if there's any cyst present. Once you do that, you have 2 curved clamp will be placed. It all depends what they want to do. When close to the ovarian ligament is normally included with the suspensory ligament to free up and remove of the ovaries, because they have to take that for the process of that. And then the wound will be considered as a class 1. So if there's some type of oophorectomy, it's pretty much removal of the ovaries. So it could be for a lot of different reasons, either for cancer or malignancy, or maybe some type of pulse infection or something. So you have to come out. Now, other procedure you see is total separaectomy. Almost the same as oophorectomy. It's the same procedure, same process, and everything else. Laparotomy is normally performed when it is created in the mesophalanx of the broad ligament between the fallopian tubes and the round ligament. And what they're doing is they will just go in and remove it, and then you go from there. So the other procedure is the same as oophorectomy. Almost the same. Let's see here. Meaning for ectopic pregnancy. And then you have endometrium ablation. Now, if patient happens to have chronic monorrhea, this is where we come into place. Go in, scrape everything out, and see maybe the patient just continue to have excessive bleeding, no stop, or that periods is normally, since it lasts for 5 days, it's been going on for 7 days or 10 days, and all those other things. So this will allow the surgeon to identify some of those things and reduce that from happening. Surgeon could require using a Yang laser, crypto laser, or argon laser, or depends which one they want to use, but you can have those things available. Again, latotomy position with general anesthesia. Once the procedure is done, patient will be categorized into a class 2 clean contaminated type of wound classification. You have myomectomy. When we're talking about myomectomy, if you look at it, pretty much talking about the middle layer, right, or the muscle layer. Everything else, myomectomy is the incision of the uterine fibroid called myomas, but it has a higher rate of morbidity and bleeding than the hysterectomy. You're looking at some of the pathological conditions that will be in there. Looking at patient could be anemia, could be a secondary to the uterine bleeding. It could be chronic. Again, anemia could be either chronic too as well, or you could have a chronic secondary dysmenorrhea. Those things will consider a myomectomy to be performed. But before they do any of these things that come down to that final conclusion, a CT scan, MRI, all these things, IVP will be done just to make sure. You would definitely need a major laparotomy set, patient in a supine position with general anesthesia, and then they will get started with the procedure. You probably want to have a Biafar or O'Sullivan or corner retractor available because now this is getting into the bigger ones now. You want to be able to see the entire organs that you're working on. So once they go in to identify what they want to get out, there could be some type of tumor in there. Use the forceps to go in, grab this thing, open it up, identify the tumor, remove the tumor. The tumor might be called a myoma. Once the myoma comes out, they can go and start closing up a deep layer of the tissue with sutures, whether it be with O or 2O synthetic as well with suture. They could use some dextrin to finish up, to close out. Dextrin may be installed to close out, and then you can do your count. And that one is wound classification will be considered as 2, which is clean contaminated. That's pretty much most of it. And then you have the other big one, total abdominal hysterectomy. It could be 1 or 2, total abdominal hysterectomy or total vaginal hysterectomy. If you're going into the abdominal cavity, it is a little bit different, the wound classification wise. If you're going towards the vaginal area, that could be a little bit different too as well. But it just comes down to what the surgeon wants to do, what they plan on doing. Anatomical structures stay the same as before. Patient will be in a supine position, with general anesthesia being administered. Abdominal hysterectomy, pretty much they're taking, a hysterectomy is a removal of the uterus, and it may be performed to treat many conditions that affects the uterus, such as it could be cancer, it could be chronic pelvic pain, it could be abdominal uterine bleeding, uterine fibroids, endometriosis, and pelvic support problem. So it could be a lot of different things. Pretty much the uterus is coming out. Uterus will either come out 1 or 2 ways. It will either come out through the abdomen, or you have a total vaginal hysterectomy approach. Okay. Abdomen might be used to get all the ligaments out and then come out to the, but again, they're going to decide which one they want to do. This procedure, one is done patient in a supine position. A lot of different instrumentation will be used here. The shoulder tenaculum, Davidson's of the round ligament, broad ligament will be identified and removed too as well. O'Sullivan, O'Connor, or the Biafar retractor or the Bookwater retractor could be used, because now we're dealing with the abdomen, so you need room to see a lot of different things or to see the full picture of the organ. Incision that could be used in this type of case could be a midline incision. Midline incision, that means you're looking at the middle part of the body, could come straight down past the umbilical and then down towards the mons pubis area. That's what they might do for cases like these. It's a big case. Once the case is done, patient will be pretty much bound to bed rest for about 6 to 8 weeks, or kind of restricted for about 6 to 8 weeks on what they can do. There could be some complications, especially when it comes down to bowel obstruction. Want to make sure that a bowel technique is actually employed in this area, in this case, or in this scenario. Class will be a class 2 wound classification. And then for the suture wise, interrupted suture will be used, and number 1 or 0 absorbable suture or staple will be used for the perineum. The peritoneum will be used, but the peritoneum will be closed over a similar manner too as well. And your textbook should give you some pretty decent pictures of a procedure like this. You have vaginal hysterectomy, it's the same thing. So you have the total abdominal hysterectomy, and then you have vaginal hysterectomy. It could be considered total vaginal hysterectomy too as well. This is just giving you a vaginal approach of the abdominal hysterectomy that was just performed. That's the same thing. There's nothing different in here. It's the same procedure, just done a little bit differently. You have laparoscopically assisted vaginal hysterectomy. Same thing as a vaginal hysterectomy, except this is being done laparoscopically. Nothing different, just the same thing, just different approach. Robotic assisted hysterectomy. This one, robotic assisted hysterectomy is different than laparoscopic assisted vaginal hysterectomy because now you're dealing with robotics, right? Instrumentations that you need will pretty much be all robotic type of instruments that you need in there. The surgeon, the difference between the laparoscopic and the robotic one is that the robotic one will be very precise, fast, quick, and easy. Well, not fast, but it could be quick and easy. The laparoscopic one, again, there could be other factors that could play into it, so you just have to account for those ones. Uterine radiation seeding, this is a procedure that's normally done for individuals that have cancer and they're trying to get a cancer out by going through some type of radiation therapy. The seed radiolucent seeds are normally implanted temporarily or permanently to treat uterine cancer. They are useful for shrinking a tumor preoperatively for a tumor that is non-resectable, or for destroying the rest of the tumor post-operatively. So if they go in, they identify the tumor has been removed, but yet and say everything was done out, they can use uterine radiation seeding to get rid of the rest. Let's just say it's hard for them to get that tumor out, then they will use that to see if they can eradicate it. Radical hysterectomy, or the Waitering procedure. This one, everything else from previous procedure is the same thing like the vaginal hysterectomy and the abdominal hysterectomy. Radical one is the in-block removal of the ovary, the fallopian tube, the uterus, and all the ligaments up until the vagina and associated lymph nodes. That means this this patient that happens to have some type of cancer cells that has either gone to, it has metastasized, and has getting into some of the surrounding lymph nodes, and they're trying to make sure that they don't go further than those surrounding lymph nodes. So they have to do a radical one to take the entire thing out. Another big procedure that will be performed by the surgeons. Just got to be ready to take over some of those cases and ready to do those cases. Now, some of the complications that will happen with the case is the bladder. There could be some type of bladder spasm. So once the case is going to have to make sure there is no perforation to the bladder. It will be a class 2 wound 2 as well. Pelvic acceleration. So this one focus on removal of the rectum, the distal sigmoid, the colon, urinary bladder, and the distal uterus and ovaries, fallopian tubes, and uterus, cervix, vagina, pelvis, lymph nodes. Yes, this is even worse than the previous one we just talked about, the radical hysterectomy, because now we're going towards the sigmoid. We're not just focusing on one end now. Everything is within the pelvic area. That's what we're focusing on. We're looking at the rectum, have to come out. The distal sigmoid colon have to come out. Urinary bladder and the distal ureters, the ovaries, the fallopian tubes, the uterus. So now we're performing everything else we just did in the radical hysterectomy in conjunction with everything else that's in the pelvis have to come out. Prognosis for patient like this, yeah, it's really not that good, not that great, really. This time now you probably need a little bit more instrumentation, not just a major laparotomy instrument set. You also need some type of vascular instrument, a kidney instrument set, a GI instrument set, an abdominal hysterectomy instrument set. Patient will still be in a laparotomy position too, of course. Patient will have to be prepped from nipple all the way down to knees for this type of procedure. Once it's done, you will see patient could be either class 2 or class 3 wound classification, or depends if there's some type of infection, if the infection spread out or it kind of burst into something else. Anterior and posterior corphorectomy. Procedure focus on herniation of the bladder and the rectum into the vaginal vault. They may occur after a connective tissue and musculature that supports the uterus become weak. When it becomes weak, then we'll have to say, okay, well, how can we go back and fix this? And so you have the cysto, it could be a cystocyty or a restocyty chorectomy. Cystocyty, we're looking at the anterior part. If it's rectocyty, we're looking at the posterior part. Want to make sure that when doing cases like these, diagnosis will be well done and patient will be examined. All those examination procedures already done, and then we can get into the procedure itself after we identify the landmark of what will be done. Other things that you consider in this case, besides just the instrumentation set, one classification will remain the same. Patient will have at least 6 to 8 weeks again for recovery time. Complications will be bleeding, hematoma, urinary tract infection, wound infection, inability to urinate, or stress incontinence. Those are just some of the complications that will happen. Sutures using this procedure will be either an O or a once entirely absorbable suture. And that's one of the surgical cases that you'll see in GYN. The anatomical and physiological of the female reproductive system. We talk about pathology of the female reproductive system, obstetric and gynecologic diagnostic procedure and tests. We talk about some of the surgical steps of OBGYN procedures. There's a lot of information in here for you to record, but one of the few things I want to leave for you is, in as much as this was a little bit long, what I want to keep with you or have you pay attention to in this chapter is knowing the anatomical structure. Okay, we're talking about female reproductive system. What are we talking about? Well, we're talking about the vaginal canal, the vagina itself, the external and the internal part of it. Whether is something below the labia minora or something kind of like above the labia minora. Looking at the vulva, looking at the fallopian tube, all those different things. Understand what the anatomical structure is. Once you understand that, the next thing I would like you to keep in mind is this different type of sutures that we use. At some point, we use, for the most part, we're using 0 and 1 suture to close out some of those surfaces, right? Other places that you probably use like a 8 or a 9 or suture was like we're doing tiboplasty, right? So consider the sutures that are being used. The position, again, position is one of the things. Position in this case was mainly a lateral position. Now, we also understand that within that lateral position, that position can provide you with multiple surgical procedures. And it is the only position that can provide multiple surgical procedures. But every surgical case begins with the patient being in a supine position. If you know those things, this will be easy for you. For the most part, most of the case classification or the wound classification, they were always class 2 or class 3. The one that became a class 1 was a cesarean section. So those simple things, it's a lot of information I'm pushing you with, but those simple things will help you out instrumentation-wise. Know your retractor. The alveolar vaginal speculum, you have the, how you call this one? The tenaculum, the Hegar dilator, you have the O'Sullivan O'Connor retractor, the Barfoot retractor, those different ones. Know your instruments, because at some point when they're asking you questions about these things, they will either give you a picture of an instrument, you have to know what that picture is, or they'll give you the function of the instrument, and you have to come up with what the instrument actually do. We already know self-retaining retractor, we know what it do, right? What it does. They just kind of like open up and retract for you, pretty much, right? So things like that, keep those things in mind when you're reviewing these sections. Other than that, that's pretty much all I do have for you. I will show you some pictures. If this is the lateral position, if I never went over it with you, this is the lateral position that we do have here. And right here, this is what I was talking about previously when we started talking about normal labor characteristic, and all this thing. You have stage 1 duration, normally 6 to 18 hours. And this is the time I was telling you now, this is the time from the onset of it all the way to the patient, to the crowning part. So this could go for up to 18 hours. And the longer, the shorter it becomes, that means that patient probably have multiple childbirth. So if it's the first time around, this could be pretty much up to that 18 hours in labor type of thing. If you already have child before, it could be a little bit shorter, right? Now, the second stage now from it normally lasts for up to 0.5 to 3 hours. This stage now is from the time the crown to the time that the child was actually born in the placenta and all those things, right? I mean, to that time. So this other one down here talk about the placenta coming out, and then this one focusing on the mother. So just some things for you to take a look at. And this is episiotomy, where we talk about the surgical TA. Yeah, so just some things for you to review. This is what we were talking about, the anatomical structure. We said the uterus is just like a pear-shaped organ. Now up here is the fundus, right? And then down here, you come all the way down, you have the vaginal opening, you have all these different, the middle portion right here, myometrium, endometrium, that's the inner part of it. And then you have the perimetrium, which is the outer part. These are the layers of the uterus. Uterus has 3 layers. The perimetrium, which is the outer part, myometrium, which is the muscle layer of the middle part, and the endometrium, which is the inner part that comes in contact. So when we start doing the DNC, we're actually scraping out the endometrium wall. That's what we're doing here. There's the fallopian tube. Of course, when we start doing tubal ligation, this is what we're focusing on. Surgical interruption of this. Tuboplasty, we're still going to take this and then reconnect it to as well. Again, just some things for you to consider when you kind of doing your study. Good luck to you. That's all I have for you for this chapter. I hope we'll meet again and continue on to chapter 16, which is our next one. But again, send me your questions. If you have any questions or concerns, send them my way and I'll be able to answer those questions for you. All right, that's it. This other chapter is done. Let's focus on the next one. Send your questions my way. Good luck.